So this is the low back pain lecture by the Ghana George Fox University physical therapy students and faculty. So the first thing that's important when treating low back patients for physical therapists is to screen out people who may not benefit from physical therapy and need other types of care. So there's some urgent conditions that include fracture, compression of the spinal cord that's leading to bilateral leg problems and reflex and sensory problems of the leg, a fever that indicates not just a low back pain problem but some kind of general medical issue, severe pain that doesn't fit with mechanical low back pain, and then pain referred to the back from either the gastrointestinal system or reproductive organs or cardiovascular system. Typically a key sign of this is that the pain is constant and not related to movement. Then there are some emergent conditions that aren't necessarily mean that we don't have to do physical therapy, but that we may need to be cautious or adjust our prognosis of what we expect. And those include nerve root lesions and spinal stenosis. So here's some of the specific diseases that cause those problems. So the urgent ones are cancer, cauda equina syndrome, spinal infections, which is connected to a fever, spinal compression or fracture, ankylosing spondylosis, and aneurysms, especially aortic aneurysms. Now, other problems that we still treat, but with more caution, is spinal stenosis, spondylolysis, spondylolisthesis, and then the lumbar nerve root syndromes. So here we're going to talk specifically about lumbar nerve root syndromes because they constitute about 5% of all low back pain problems, and it's something that we still may help with management of. So we see here that the lumbar nerve root is coming out of the intervertebral foramen of the spine and then forms the sciatic nerve and then runs down the posterior leg, innervating the skin and many muscles. The things that compress the nerve can be the disc, or if there's some type of fracture involved, or cancer can all compress the nerve. Typically, it's a part of the disc. A sign of this is pain that's primarily in the leg and constant and unrelenting and oftentimes severe. One of the ways we can, if the person has both low back and leg pain, we can be biased toward a nerve kind of problem is when the leg or nerve pain is worse than the low back pain. The signs that we would see are a positive straight leg raise. So when the person's lying on their back with the knee extended and we raise the leg up, the sciatic nerve here is on the posterior aspect of the leg, so it's getting stretched. And the stretch in the sciatic nerve causes increased pain, which is an indication that the nerve itself is inflamed or the root is giving rise to pain. If it's connected with motor loss or sensory loss or reflex loss, those are all signs that there's a nerve root problem. And so specifically, we can go through the exam findings here where the low back pain is at least equal to the leg pain is below the knee, and oftentimes the leg pain is much worse than the low back pain. Flexion is painful. There is a weakness in the muscle that's associated with the nerve root. The sensory distribution that's associated with the nerve root. Absent reflexes, either at the Achilles tendon or the patella tendon, and then the straight leg raise is positive for pain below 60 degrees of hip flexion, and that's the key. And early prognosis and profiles of these people is interesting, where about 40% of people with leg pain below the knee didn't qualify as nerve root syndromes, essentially because their back pain was still way worse than their leg pain. And then about 30% of them improved significantly by 12 weeks. So even though the pain is quite severe, it can resolve on its own. And then about 7% went to surgery prior to 12 weeks. So if we look at the prognosis for this syndrome, it's paints a picture of very severe early pain, but then over a long period of time, of about a year, there's some significant recovery. So we look at people, like the overall group is classified here on the right, and we can see that the amount of disability at the beginning, at the 12-week point at least, was around 30, where on a 100-point scale. So basically, they were quite disabled, and the leg pain was on a 0 to 100 scale was 50, and the average low back pain was about 50. So if we look here, compare people who had surgery and didn't have surgery, what we notice is that the people who select surgery have much more severe pain. Here's 70 on a 100-point scale in the leg and 64 in the back, and disability is a bit higher at 40%. Versus the people who choose not to have surgery or can tolerate it are 28 in terms of disability and around 50 in terms of leg and back pain. But at 52-week follow-up, we can see that disability has gone to 0 in the surgery group, so it went from 40 to about 10, and it went to about almost equal value in the no surgery group at 16, so just a little bit more disability. And then if we compare pain, the pain's relatively equal also. There's a significant decrease in both groups, in around 20 and 18, so very acceptable levels for most people. And so in the short term after surgery, the pain is better quicker than people who don't have surgery, but in the long term at 52 weeks, they're relatively similar in terms of their disability and pain profiles. So for this reason, surgery is an option. It depends on the patient profiles and their ability to tolerate their pain. And the good news is that even though medicine is not that effective in relieving their pain in the short term, in absence of surgery, long-term prognosis is excellent. So for this reason, physical therapy is often involved in helping patients manage their pain, and it can be things like one thing we know clearly is that bed rest is negative for these individuals and leads to increased disability. So if we can help them stay active in spite of their pain, that's a positive. Still, some medications are helpful in terms of pain management, their ability to return to work, and encouragement that they should expect a good and complete recovery despite slow progress, and continued pain is important. Note over here that at 52 weeks, over 65% of everybody was essentially not disabled after having this problem. Okay, so that's a type of treatment that we don't have as effective tools to deal with in terms of physical therapy, but that's luckily for us and individuals, that's not the most common type of low back pain problem. Typically, 80% of patients have exam findings where the primary complaint is low back pain and pain that's proximal to the knee. The pain is intermittent, which means it comes and goes. It's not constant, and it's improved with some activities and worse with others, and that there's no effect on lower extremity muscle strength, reflexes, or sensation. And for these individuals, the expected recovery is excellent, where although the initial pain complaints can be quite severe. For example, a recent study demonstrated that at the emergency room, people report almost complete disability with this type of pain profile, where they're 83% disabled. But by day 7, after their follow-up visit, they have essentially decreased their disability to about 42%, and then at a 3-month follow-up, it's nearly 0. So for these individuals that we're only giving essentially muscle relaxants and placebo, the outcome is excellent. So what physical therapy can offer these people is one, a more rapid decrease in their disability and pain, and two, prevention of long-term disability by keeping them active and essentially restoring some of the function of their low back. So to approach this problem, people get classified into different categories of low back pain treatment. So some patients, it's effective to do a specific exercise category. For other patients, it's more effective to do manipulation. And for other patients, it's more effective to do stabilization types of exercises. So to classify people into the specific exercise classification, we're going to look for a directional preference in movement where that either peripheralizes or centralizes their low back pain. And so and the key is whichever activity centralizes their pain is the preferred direction. For manipulation, if there is no preferred direction and the onset was relatively soon, within less than 2 weeks, and there's no symptoms distal to the knee, then manipulation is a good choice for some immediate pain relief. If they have if they have these following signs where they have the prone instability test as positive and the positive aberrant movements, they're younger, and they have an SLR that's quite high, it's indicating that their muscles are having trouble stabilizing their back, and that may be one of the reasons for their pain. And so then they're put on a stabilization program, which has some benefits in terms of pain relief. So we're going to start with more detailed explanation of the specific exercise classification. So who is a good candidate for this particular classification? Well, the key here is that one of the movements causes a centralization of pain versus a peripheralization. So it's frequent that flexion can cause pain to start in the back and then radiate down the leg, even past the knee. So an indicator that is a bad motion to move in after low back pain is that the pain moves distally or toward the foot or knee from the back. Centralization is when the pain goes from the distal region to the proximal. So patients who consistently feel centralization of their symptoms with repeated movements of the trunk in a certain direction are good candidates for this classification. So that can be extension exercises, flexion exercises, or side bending exercises. So in order to classify people, we first have to have them ask questions about different positions that might make them feel worse. So typically people who have a directional preference feel better sitting or standing and walking. So people who like extension don't mind walking. People who don't like flexion direction have a difficult time like sitting, for example. Then during the examination, we'll have the patient bend forward 10 times, ask them if their pain's getting better or worse, and then also where their pain's located. Then we'll have them bend backwards 10 times, and we'll ask them again if their pain's getting better or worse and where it's located. And based on if the pain peripheralizes or centralizes during those 10 repetitions, we'll prescribe either a flexion or extension type of movement. The typical profile of a person that has an extension preference is symptoms distal to the buttock, but not distal to the knee. Symptoms centralized with lumbar extension, so there's more pain in the low back with extension, but less in the leg. Symptoms peripheralized with lumbar flexion, so that makes them go distally in the leg, and patients feel better with standing or walking. The profile for flexion is that they're typically older. They have a directional preference for flexion, so flexion, things like sitting, bending forward relieve their symptoms. So the interventions for this include, for the extension preference category, end range extension exercises, mobilization to promote extension, avoidance of flexion activities, mobilization or manipulation of the spine and or lower extremities, and exercises to address impairments of strength and flexibility. For flexion, the primary difference is that the mobilizations or manipulations of the spine and lower extremities are to promote flexion, not extension, that the exercises address impairments of strength and flexibility, again directed at flexion, and then just general fitness. So this is an example of some of the extension exercises. One of the key ones is the prone on elbows, and also into an extension, and this can also be done in a quadruped position. And then the flexion exercises we can see here, a variety of choices. Essentially, there's a seated flexion exercise by squatting. When you get into full squat, there's some amount of flexion in here. We see knees to chest, which is a early acute phase flexion type of exercise. This next section has to do with nerve gliding, which is often combined with the specific exercise group. And so if a nerve gliding exercise is indicated, you can do this kind of stretching, which helps in terms of increasing mobility, especially into flexion. With the concept being is that the nerve root can get stretched somewhat during the flexion movement. So the first thing that's done is the sciatic nerve is targeted, and the straight leg raise is executed, and then ankle dorsiflexion is added. If ankle dorsiflexion accentuates the pain or restriction in range of motion, then that's a positive test, and neurogliding may be indicated. So the person can be stretched in a supine, where they lift the hip into flexion with the knee and extension, and then dorsiflex the ankle. Hip adduction and internal rotation can also increase the stretch on the nerve. Selective tension in the nerve can be provoked with dorsiflexion eversion for the tibial nerve, dorsiflexion inversion for the sural nerve, and plantar flexion and inversion for the common peroneal nerve. The next category to consider is the manipulation category. But before we do, it's important to note what types of diseases shouldn't be considered for manipulation, because it's a relatively high velocity, high magnitude stretch of the lumbar spine. And so if someone has a fracture, they're very unstable, or bone malignancy, bone infection, bleeding, central nervous system disorders, they tend not to respond very well. And especially something like osteoporosis, the thrust could be damaging to them. And then, of course, because it's a high velocity and high magnitude procedure, there could also be other types of things that it doesn't necessarily have not ever to be done, but it should just be very carefully considered. Things like benign bone tumors, pregnancy, someone's hypermobile anyway, or someone's spinal listhesis where the spine's abnormal in the first place. You could add scoliosis there as well. So just recognizing that manipulations work best when the anatomy is fairly normal and the episode is a straightforward, non-specific low back pain, acute type of injury. And following up on that, some of the criteria for the manipulation category is that they're relatively recently injured, they have very localized symptoms to the back, and they have a hypermobile segment. So that's the subjective. But then in the clinical presentation, a lumbar spine manip would be indicated by restricted motion somewhere in the back that's assessed with something called a posterior to anterior pressure. They're not fearful of movement, so they're comfortable with their back pain. They're just looking for some help to get moving. That's the case where a manipulation is going to really work, especially the lumbar spine. And then if the signs are instead focused on the sacroiliac joint, where you have things like a positive Faber's test, a positive distraction test, a thigh thrust test, or Ganslin's test, those things would indicate a sacroiliac joint manipulation would be indicated. So selecting who manipulation is appropriate for is important first, and then where to do it, either lumbar or sacroiliac region. Once you've decided that a manipulation is appropriate, some of the different options in terms of manipulations you could administer is something called a lumbar gap, neutral gap procedure that could be biased toward flexion extension, essentially. And you can see here that this is a standard technique. It's fairly straightforward to perform. Most patients tolerate it very well and has good pain relief associated with it. If you're having trouble getting that in the position, sometimes you can do a thoracic technique to help relax the back muscles. And then if the test exam indicates that maybe either alone or together with the other techniques, a sacroiliac technique may also help relieve their pain. That could also be included in your suite of manipulations you perform. So this is a demonstration of a lumbar roll technique, which rotates the lumbar spine toward the side that's up. And so here this person's going to be rotated in a left rotate of the lumbar spine. So the position is important, and then the way that the thrust is administered is also important. This is a high velocity technique, so the force needs to be rapid, smooth, and not beyond the physiologic range. So we can see the beginning of the positioning is the bottom leg is extended at the hip and the top leg is flexed at the hip. Usually the foot's placed in the nook of the knee there. And then the person is inducing some slight amount of rotation of the lumbar spine. And then the upper arm is extended, and then the bottom arm is pulled through, inducing rotation to the left in this case. Now the therapist then will engage the trunk with his forearm and then feel the movement of the spine with his hand. And specifically, the spine is processed at L5. And once the slack is taken out, he's going to thrust with his opposite hand on the pelvis. And now the slack's taken out, and here it comes, the thrust. And then that would oftentimes be associated with a pop, which would indicate that the joint had been successfully moved. Outcome for manipulation is a pretty strong change in pain. If not immediate, fairly soon after. And you can usually assess this by having them repeat some of the standing, side bending, forward flexion, backward flexion that they perform, and at least something about their movement should be better if the manipulation has been effective. This also should help them tolerate their exercises better, and therefore you'd want to use the manipulation as a way of getting them moving and getting them into self-managing their own problem. So the final classification we're going to discuss is the stabilization category, which we theoretically think of as a group that has too much mobility in their lumbar spine. And these people are characterized by being younger, so their spines are more mobile. They get stiffer as they get older, so at some point the need for stabilization from the muscles decreases. Their straight leg raise is greater than 90 degrees, indicating that they have a lot of mobility in general, that when they move, they may display aberrant movements when they're, for example, returning from a flexed position. And the prone instability test may be positive. These are all indicators that the person falls into this category and could benefit from stabilization exercise. So first, an abhorrent movement. Typically, it's a click or a deviation from a smooth transition forward, and then they may illustrate something called a Gower sign, which we can see here to the right, when returning from flexion to an upright position and standing. And what they'll may do is put their hands on their knees so that they can push their back up, and that's a positive Gower sign. We can see that illustrated here. Now, they may also have an instability or catching sensation that they have to move through, and once they've moved through that, then they have less pain. Those are all what we would classify as aberrant movements and would mean that the stabilization category of exercises may help them. The prone instability test is illustrated here to your right. And essentially, what you're going to do is position the person in a prone position with the knees off the end of a table. Then you're going to do a posterior to anterior pressure. You can see that the hands are crossed over each other and the person's pushing down on a specific segment of the spine. Once you find a segment of the spine that this is painful for, you're going to induce that pain somewhat by your pressure and then ask them to lift their legs off the table. When they lift their legs off the table and you're still maintaining that pressure, if the pain goes away with the muscle contractions induced by lifting their legs off the floor, well, then that's a positive test that the muscles reduce the painful symptoms and that they may stabilize the person's spinal vertebrae, thus reducing their pain overall. So this is a good test, a strong indicator that stabilization exercises may be helpful to them. In terms of stabilization, there's 3 different ways of thinking about it. The first way is just overall power. So we can apply a load to the back and the back ligaments, and essentially we see the first peak here. It's way below the threshold of error or injury, and that's labeled tolerance in this picture. Now, we could apply a much larger load that would take us to the injury tolerance or capacity. Now, we may also reach injury tolerance by repeated loads. So essentially, if we repeatedly load a ligamentous structure of the back, its tolerance for injury gets lower and lower until if we repeat it so much that basically even though a low load's being applied, it exceeds their injury tolerance. And the last example of overloading occurs when we just hold a load for a long period of time. And so if we just hold a load for a long period of time at a constant load, the injury tolerance also decreases over time until eventually the small load is sufficient to exceed the injury tolerance. And so the power situation here would be an example of some kind of trauma or athletic movement that was quite extreme. The endurance example would be from maybe a construction worker that's digging with a pick or a tool all day long, and they're repeatedly all day forward bending to dig a trench, and that person may eventually exceed their injury tolerance. The postural syndrome is somebody who is sitting all day perhaps, or has to assume an awkward position for an extended period of time. Eventually, even something that doesn't hurt initially could become painful. So the 3 core endurance tests we can use to try to rehabilitate the low back muscles to be able to handle this primarily an endurance capacity to handle the repeated loads and poor postural positions that the spine may assume. And it should be emphasized, these should be pain-free, so they're not appropriate for acute low back pain patients. They're called the lateral musculature test, the flexion endurance test, and the back extensor test. So this is the lateral muscular test where the person's on their side and attempts to hold a side plank position for as long as they can. Typically this will work the lateral muscles of the back, particularly the muscles facing the ground. And we can time this to see how long they can hold it before they fatigue. And here's some reference times for you to use. The flexion endurance test is we start the person in a semi-reclined position, holding their feet with their knees and hips flexed. And essentially we ask them to bring their back away from the support and hold that position for as long as they can. And finally, the back extensor test, where we have the person lying prone on a table, and then they, with their usually some kind of support out in front of them so they don't have to flex too far, and then they try to lift their trunk up and release the support holding their trunk horizontal with the legs for as long as they can. And then that's timed. So those are the 3 tests we can use to try to detect weakness. And with the two tests, or the one test with the side bending, we can do a ratio between sides. So if the right lateral test is different than the left lateral test, then that's an indicator that the stabilization or core exercises could really help them. If their flexion extension ratio is less than 1, then it suggests that they could use greater rehabilitation for that. And then the lateral test score versus the extension score should be less than 0.75, meaning that they have a lot more ability in terms of their lateral test time versus their extension score time. There's a protective effect when they meet these criteria in terms of balancing their lumbar spine ability. So the rehab concepts are: stabilization involves all muscles of the spine, so doing all 3 directions tends to be preferred versus just one. And then, integrating these activities with functional tasks is also important. So the big 3 here, you can start once you put somebody in this category. Some ways to address those test results are to do side planks, start with the knees bent, and then move to where the knees are straight. And then the bird dog exercises helps work on the back extensor muscles. And then the curl up exercises here, where you do partial range curl ups, works on the abdominal muscles. So there's increase your lateral musculature with side planks, increase your back extension time with the bird dog exercises, and then we would also be working on curl ups with the flexion exercises with the curl ups. The key of the stabilization exercise program, it's comprehensive. Programs should include the functional exercises such as squats and lunges as well, so they're activating the pelvic muscles in terms of the glutes and iliopsoas muscle groups. And then finally, we would integrate these activities with advice relative to forward bending, where somebody who's had trouble with forward bending or has problems with stabilization, flexion activities are more damaging to the spine than activities that keep the spine straight or teach people to lift with a straight back. So here's our first case. So in this particular case, we have a 54-year-old male with low back pain that radiates into his thigh. The patient reports the pain started 3 months ago and worsens after he has been sitting for 30 minutes and gets better when he stands up and walks around. So range of motion is limited in flexion due to pain and normal in all other directions. Pain returns to the low back during extension, but there's no thigh pain. The prone instability test is negative, and the straight leg raise test is positive. Central PAs, so that means posterior and anterior pressures in the low lumbar area, show normal mobility. So if we think about this particular case, we can ask the question, what category does the patient fall into, and what are the three treatments you could provide this patient? So essentially, some keys from this case are that flexion increases pain and peripheralizes it, but the pain returns into the low back, so actually centralizing pain with extension. Okay, in that the patient reports flexion exercises as worse, so sitting, which flexes the spine and increases disc pressure, and extension relieves pain, i.e. walking around. Okay, and the pain is not acute. He's had it for several months, so he wouldn't fall into the manipulation category. So this is a good patient for the specific exercise category, and a good choice for him would be to try the extension exercise program, especially if he responds to repeated movements with further centralization. He could be progressed from there to a stabilization approach to try to ensure that he doesn't have recurrence. So in the second case, the patient is a 34-year-old female with low back pain that comes on when changing positions. She reports a feeling of catching when the pain occurs. She demonstrates using hands to climb up thighs when going from sit to stand, and when returning from into upright from a flex position. When she flexes, you can see a little movement of her back to the right or left, and with a flexion endurance test, she's only can do it for 53 seconds. When you apply a posterior to anterior pressure, she shows some hypermobility with central PAs in the low lumbar area. The highlights for this case are that she has some hypermobility in general. She has decreased core strength. She demonstrates these aberrant movements and catching sensations which are consistent with the stabilization category. So a good approach for her would not to be doing too much stretching or range of motion types of things like manipulation in the lumbar spine, but instead to start in with stabilization exercises straight away and expect slow, steady progress rather than rapid decrease in her pain, which can be brought on by manipulation types of treatments. Well, thank you for listening. These details will be reviewed in the laboratory and as we see patients together in clinic.